this next one, we'll go to Dr. Taneja. Can you explain what a biochemical relapse is versus a clinical relapse in multiple myeloma?
Yeah, sure. Biochemical relapse is based on, if I could just tell you in very layman terms, I would say that it's based on what's going on in your blood and your urine in terms of your myeloma tests, like your the protein electrophoresis we get, the free light chains that we check as well. And clinical relapse is, we call a relapse clinical when you have some symptoms that are clinically manifesting, when you have a relapse. So somebody might have a new bone pain, a new fracture, in which case we would call that relapse a chemical relapse. We do have the International Myeloma Working Group criteria that can give us the best guidance in terms of assessments for progressive disease. And, we have to measure how much there has been an increase in the M spike and the free light chains in the blood, and the urine to, exactly define over 2 different time points progressive disease. Yeah, that's my take on that question.
Yeah, I mean, really, clinical relapse is what we're trying to prevent or at least delay in multiple myeloma. I mean, you're feeling bad related to your cancer. While biochemical is just a lab test that comes back, and you're feeling fine. Typically, though, biochemical relapse is going to happen before the clinical relapse, usually, or almost always. So I can only speak how I do it in my clinic. When patients are in a good remission, whether they're on or off maintenance, I will follow that protein in the blood on a regular basis. And if it starts going up, if it just goes up a little bit, and the patient feels fine, I watch it. And I've definitely had patients where that's what makes myeloma a hard disease to treat. I've had patients to get a transplant and like 6 months later, their M spike recurs and we're all freaked out. And then we watch it. And then like years later, it's just kind of staying there and nothing's happened. And I could have started treatment 3 years earlier, which would have been not necessary. And that's where the art comes in. So if I see a biochemical relapse, I will follow it closely. Now, if it goes from 0.5 to 1 to 1.5, we're in trouble. Okay. But if it just hovers around, I typically don't do anything or change my treatment plan. And this is just where a judgment call has to happen in a discussion with the patient physician.